Hello, everyone. My name is Subarna, and I'm so happy to welcome you all to the fourth annual Cannabis in Practice webinar series, hosted by the Washtenaw County Health Department in partnership with the Washtenaw County Medical Society. This virtual series is aimed towards healthcare providers with the goal of raising awareness and opening discussions surrounding cannabis use for medical practices. Our speakers come from a wide range of backgrounds and are experts in their respective fields related to medical cannabis. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. I'm so pleased to introduce today's speaker, Dr. Kevin Boehnke. Kevin Boehnke is a research investigator in the Department of Anesthesiology and the Chronic Pain and Fatigue Research Center. Kevin received his doctorate from the University of Michigan School of Public Health and has also completed yoga teacher training. His current research focuses on therapeutic applications of cannabis and psychedelics. His goal is to rigorously assess appropriate use of these substances, as well as to help address the public health harms caused by their criminalization and misuse. Thank you so much for joining us today, Dr. Binky, and I'll pass it over to you.
Thanks so much for that kind introduction and for having me today. I'm just going to share my screen real quick, and we'll get into things. Okay, so before jumping into the meat of my talk, just a few disclosures. Sit on a data safety and monitoring committee for an ongoing clinical trial with a cannabis company called Vero Health. I've received protocol development funding from a couple companies related to psychedelics, and then I have NIH funding as well as funding from the state of Michigan. So before getting into some of the legal and other aspects of cannabis for pain, I just want to do a couple definitions. So, there's all these terms thrown around these days: hemp, cannabis, marijuana, and all of these actually refer to cannabis sativa. You can't really look at a cannabis plant and tell how much THC or CBD or what other content it has. Generally, hemp refers to cannabis with less than 0.3% THC. These plants are the ones from which a lot of the descheduled CBD products or cannabidiol products are made. Marijuana, on the other hand, typically refers to cannabis that has more than 0.3% THC. It was used historically in cannabis prohibition campaigns as a way of kind of drumming up racism and xenophobia. So I tend to stay away from this term. And I like the term cannabis as it's both the most accurate and the least offensive. So just a touch of history and context here. So cannabis has been used for thousands of years for medical purposes. In fact, in China, one of the emperors wrote about prescribing medical cannabis for rheumatism and pain. That use continued in antiquity with the famous Greek physician Galen prescribing it as medicine. And this largely continued, including in the US, until the 1930s when the Marijuana Tax Act passed, which required special fees for prescriptions of drugs. And at that point, it was removed from the US pharmacopoeia. But before that time, there were just many, many different formulations that people talked about using for medical purposes. Now, despite the resulting illegality that ensued from the Controlled Substances Act in the 1970s, which made cannabis a Schedule I drug, and by definition meant that it had no accepted medical purposes or value in the US, the FDA actually approved synthetic THC for cancer patients. So this synthetic T compound is called dronabinol, as well as for AIDS-related wasting syndrome. So there's obviously known therapeutic value of cannabis and these compounds from it. And then in the past 25, 30 years, we've seen a lot of Western countries adopt medical cannabis laws that have allowed access to cannabis for various different conditions, including pain. And this has really accelerated, especially in the past 15 years or so, in some ways because of the opioid crisis, in which many people are dying of opioid-related overdoses, and some of this is because of poorly managed chronic pain. And so there's been quite a bit of research, including some that I will highlight today, where people have said, I've been using cannabis as a substitute for opioids, for other pain medications, finding it to be potentially more helpful. And that has really thrust cannabis into the mainstream as this opioid alternative. So with that context then, here's the general outline of the talk. I'll just touch briefly on the legal situation, both nationally and then in the US, then in Michigan. Talk some about cannabinoids effects and ingestion, the risks and benefits that we know of generally with cannabinoids, what their role is in pain management, and then some stigma and barriers and ways that we can overcome those, as well as synthesizing this all together to provide practical and pragmatic approaches to actually work with people who are using cannabis so that they can optimize that use for medical benefit and minimize some of the harms associated with that. And I know that sounds like a lot, but we should still have plenty of time for questions after that as well. So as I mentioned, many states have cannabis legal at this point for medical purposes, about 37 at this point, and I believe 19 for adult use, despite cannabis being Schedule I under federal law. And this mismatch not only has blocked effective research on the therapeutic properties of cannabis, but it of course has inflicted a huge amount of societal pain. So just to give you a couple statistics, in 2018, there are 663,000 arrests for cannabis in the US compared to only about 520,000 for violent crimes. Most of these arrests were for simple possession. And not only that, but they were disproportionately occurred among poor Black and Brown communities. And this, contributes actually to many of the downstream health effects that that many people try to manage with cannabis. So there's this really nice viewpoint published in JAMA Psychiatry that talks about how we actually need to consider a broad range of other potential psychosocial outcomes of incarceration related to cannabis criminalization, which includes depression, anxiety, trauma, years of life loss of family and social ties, and then things such as voting disenfranchisement, all of which have these long-term negative effects on people and their communities. So despite this criminalization background, something that has stayed increasingly and been made increasingly clear is that cannabis is not going anywhere, especially for medical purposes. So these are data that my colleagues and I recently published this year, looking at all the patients with medical cannabis licenses in state registers that have available data. So this notably excluded states like California, which have potentially over 1 million patients. And we see, over a 400% increase in the number of patients from 2016 to 2020, from about 680,000 to over 2.9 million in that window. So just a dramatic increase. And the most common reason that people actually use medical cannabis and obtain those licenses is for chronic pain. That's more common than all other conditions or symptoms put together. So just showing the ecological plausibility and importance of honing in on chronic pain as something that we need to study, whether cannabis is useful for managing those symptoms. So specific to Michigan, we actually have a pretty long-standing medical cannabis program. The Medical Marijuana Act with an H was passed in 2008. And in 2021, there are about 250,000 licensed patients in Michigan. And similarly to those statistics that I showed you from nationwide statistics before, much of that use is for chronic pain. So there's actually numerous different pain symptoms that people can select to get a license in Michigan. And 61% of those 250,000 selected chronic pain, 44% selected severe and chronic pain, and almost 20% selected arthritis. So lots and lots of cannabis use for pain in the state of Michigan. Just to give you a sense of how this looks at a legal level, typically a patient fills out an application for the state. They have to have a healthcare provider that might be their primary care physician, or could be somebody from one of these certification clinics who sees them once and never sees them again, sign their application certifying that they indeed do have the medical condition or symptom that qualifies them for cannabis under state law. They get issued a license. Almost nobody will put their face on that license or send a photo with it. And then at that point, they can either possess 12 plants as well as 2.5 ounces of cannabis at any time. They can also designate a caregiver who could grow that cannabis for them, and also they can go to medical cannabis dispensaries to purchase products there. We also do have an adult use law in place, which maps on quite similarly to the medical law as well. So any adult can have those 2.5 ounces of cannabis in public. They can also have 10 ounces at home, and they can grow 12 plants in their residence. That being said, your employer still can drug test, and you can be fired for using medical cannabis, even if you have a license in a workplace, and same goes with recreational cannabis. So just because we have these statewide laws, because cannabis remains Schedule I at a federal level, especially institutions that receive federal funding, there's a lot of concern there to make sure that funding is not jeopardized. So then moving into cannabinoid effects and ingestion. So while there are many, many cannabinoids found in the cannabis plant, over 100 at this point, the two that are most commonly studied and used are delta-9 tetrahydrocannabinol, or THC, and cannabidiol, CBD. So THC is the compound we most associate with the cannabis high. It's analgesic, it's mood altering, it's appetite stimulating. While in contrast, CBD is non-intoxicating. It actually has some potential protective effects against the psychoactivity of THC, especially the anxiety-provoking mood alterations that can happen with too high of a dose of THC. It also has known and strong anticonvulsant properties demonstrated by clinical trials with Epidiolex, which is an FDA-approved CBD product that is actually plant-derived. And used in clinical trials with Dravet syndrome and Lennox-Gastaut syndrome, so orphan epileptic conditions. There's also a growing body of evidence suggesting that CBD might be anxiolytic, and then in some non-human animal studies showing a pretty potent anti-inflammatory effect. So there's now a few clinical trials ongoing, including some that I'm involved with, where we're trying to see if those non-human animal studies, those anti-inflammatory effects do translate over to humans. So there are many other cannabinoids, as I already mentioned, like CBN, CBG, CBC. And I mention this not because we have almost any research on those, we don't, but just so y'all know that a lot of times people will ask healthcare providers, well, should I use THC isolate or CBD isolate, or should I use what's called a full spectrum product, or something that has all of these other compounds in it? And this is, I'd say, still an open question at this time, but it's more of a philosophical debate between more of the herbalist camp, where the whole is greater than the sum of the parts, versus the classic pharmacology camp, where you say, well, let's extract the single ingredient and put it in something like Marinol or Epidiolex, and that's where you get the therapeutic effect. In terms of how the different ways that people ingest these compounds affects the body, the most common administration routes are smoking and vaporizing, edibles or oral routes, oral mucosal like tinctures, and then topical products. So there are advantages and disadvantages of each of these routes. Briefly, smoking and vaporizing has a very fast onset, so people usually get peak effect in 5 to 10 minutes, so it can be very easy to titrate. But of course, inhaling and combusting cannabis is not especially great on the lungs. So if somebody is insisting on inhaling, vaporizing is likely a better choice because it doesn't fully combust the plant material. But it also is not especially discreet to do either one of those things. Edibles avoid that issue, but the onset and the effect onset is considerably longer. So usually 60 to 180 minutes, which means that the classic thing that many people have happen is they'll eat some, they'll wait a little while, they'll think, okay, I'm not having much of an effect, eat more, and then when it all hits them, they might be pretty uncomfortable. So it's just super important with edibles and oral roots to be patient and make sure that they're waiting for your peak effect. And these can last, 6 to 8 hours, depending on the dose. They can last much longer if people eat way too much. Now, sitting in the middle ground between inhaling and edibles are tinctures or oral mucosal roots, which typically, if held under the tongue for 2 to 3 minutes, can take effect in 15 to 45 minutes. They have a similar length of duration as edibles. And actually, CBD products are this is the most available form of CBD products that people buy outside of dispensaries, because again, these are descheduled products. And then lastly, topicals. There's a lot less known about these because it varies so much on formulation. Like if the product has something that allows the CBD or cannabinoids to penetrate the skin and act systemically, you might get a different effect than something that just stays on the surface of the skin. So still a lot more to be known about topical products, but at this point, I think the general consensus is using it on a superficial joint or place that there's that localized pain is probably the place that there'd be most likely to be some kind of therapeutic effect there. So going into the risks of cannabinoids, as with any substance that you put in your body, cannabis and cannabinoids have risks associated with them. I think much is made of the fact that it's very hard to have a lethal overdose from cannabis, and I think that's really important to note, especially when you compare it against opioids or benzodiazepines or something like this. But it by no means indicates that cannabis is completely safe. So in the long term, there can be some persistent respiratory effects of cannabis, especially if it's smoked. Also, it's possible to develop dependence and addiction to cannabis and cannabis products, especially when use starts in adolescence or in young adulthood. And then there's some suggestion that there's higher rates of psychotic illnesses developed, especially when use begins under the age of 25. Causality still is not fully determined with this association, because some people may end up using cannabis to help manage or to try to manage some of those symptoms. So there's still quite a few unknowns there about whether there's a causal relationship where some people actually stimulate a psychotic illness as a result, but it's still, in people who have a family history of schizophrenia or other psychotic conditions, caution is definitely warranted there. In the short term, some common side effects include things like dizziness, somnolence, euphoria, anxiety, and others. Less commonly, vomiting, hallucinations, paranoia, etc. And I think one of the big issues is uncertain quality, especially for the illicit market. At this point, we in Michigan have statewide testing that occurs, or state license testing that occurs for products that show up in dispensaries. So those have to get tested for mold, for pesticides, for heavy metals, for other compounds that might show up in the processing of these products. So there's at least that in place. That doesn't mean that we haven't had big recalls in Michigan of cannabis products, but there's at least that baseline level of testing. And so the picture that I put up there, you'll see cannabis that has some bud mold in it, which you don't want to smoke anything with mold and inhale that into your lungs, especially if you're compromised. And then lastly, as cannabis does cause intoxication, there is a higher chance of things like vehicle accidents when intoxicated. So avoiding getting behind the wheel of a car, operating heavy machinery is really wise when using cannabis. Most of those risks, though, are associated with THC and recreational use of cannabis. So I'm just going to highlight a couple risks of CBD. This is a pretty remarkably safe cannabinoid compound. Multiple studies demonstrate the safety of pretty high dosing regimens, like greater than 600 milligrams a day. Just to put that in context, most people, when they buy a CBD tincture or capsule or something like that, are taking anywhere between 10 and 50 milligrams a day. There's also known drug-drug interactions, which can inhibit or affect liver enzyme activity, which can affect CBD plasma concentrations or affect the concentration of other medications that are being taken simultaneously. Much of these data are drawn from the Epidiolex studies with Dravet and Lennox-Gastaut syndrome, where the participants in those studies were taking quite a few medications to help with those seizures. So whether those risks apply necessarily to those sorts of low dose paradigms that I was talking about, that 10 to 50 milligrams a day, we just simply don't know at this point. And same with the side effect profile of Epidiolex at these high doses. You see things like drowsiness, decreased appetite, diarrhea, rash, difficulty sleeping, or malaise. But I think at this point, for people who are planning on testing or trying out or trialing CBD for pain management, the biggest issue is one of quality control, especially if they're not buying these products from state dispensaries, because you can buy these at gas stations. In Ann Arbor, where I live, you can often buy them at supermarkets. So there's many fewer levels of regulation around these products, and there can be pesticides, solvents, and heavy metals left behind by sloppy manufacturing. And in fact, there have been numerous news reports and scientific papers at this point showing that some of these products are contaminated with these compounds or even synthetic cannabinoids. Excuse me. So moving then into the use of these of cannabis and cannabis products in pain management. I'm going to talk a little bit about how I and the folks at the center that I work at think about pain, think about how that applies to the clinical trials that we have in the literature, and then highlight a few naturalistic trends because they actually diverge quite substantially from how clinical trials are conducted and can provide some useful real world information about what's going on. So first, the mechanistic characterization of pain. So at the center I work at, we think of pain coming in 3 different buckets: nociceptive, neuropathic, and then centralized, or the new term is nociplastic. Nociceptive pain is due to more inflammation or tissue damage, with the pain localized to the location of that damage. You can think of something like cancer pain or osteoarthritis for this. In contrast, neuropathic pain is due to nerve damage or entrapment. The pain will follow the distribution of the peripheral nerves and have sort of a different character, like episodic and feelings of numbness or tingling that can go with that. And an example of this is sciatica or carpal tunnel. Lastly, the centralized or nociplastic style pain is widespread throughout the body and often moves around, and there's a history of that pain. And it tends to be accompanied by a cluster of co-occurring symptoms that might include fatigue, sleep, memory, or mood difficulties. And this tends to be a very difficult to treat type of pain, with the prototypical centralized or nociplastic pain condition being fibromyalgia. So all of these can occur together in what we might term mixed pain state. So somebody with fibromyalgia could also have a repetitive motion-related carpal tunnel injury and then have cancer-related pain. And unfortunately, the cannabis clinical trials for chronic pain at this point don't really tell us much about the breakdown of how cannabis might affect either nociceptive or that centralized nociplastic pain. There's some support that especially this product called Sativa, which is a 1-to-1 THC to CBD sublingual spray, might have some benefit in neuropathic pain, mostly associated with multiple sclerosis. But while it's a statistically significant difference between those products and placebo, the clinical significance of that pain relief is not especially strong, given that there's also increased risk of short-term adverse events, albeit they're mostly minor for study participants. There's been some concern about whether or not there's actually some benefit there for most types of pain. That said, all of these trials and the many systematic reviews that have been done have been panned pretty much because of short length, small sample size. The generalizability is pretty poor to the products that people can get in dispensaries. For example, many just use THC alone, or this one-to-one CBD to THC product that actually isn't available in the United States. And not only that, but the formulations are far, far different than what we see in naturalistic use. So just to highlight again, some of these products that people can have been used in clinical trials, the synthetic THC, Sativex, Epidiolex, and then that bottom picture, you'll see a picture of Dr. Mahmoud El-Soli, who runs one of the only legal grow sites for cannabis in the US, funded by the National Institute on Drug Abuse. Those products don't really match, and he's holding a handful of ground up cannabis powder. Those products don't match with what you see in dispensaries. So anything from a, chewy caramel bar that has 115 milligrams of cannabinoids in it, to creams, flour, topical products, all sorts of edibles, sodas, etc. And not only are the products wildly different formulations, but people use them differently. So just a couple examples of this from a couple publications from myself and my colleagues. We see that most people using cannabis for chronic pain, so this was a cross-sectional survey of 1,321 people, and about 1,276 who answered this question, but 93% use 2 or more routes of administration, with 72.5% using 3 or more. We see that people use a wide variety of THC and CBD products. And then just to give you some examples of how this might look in somebody's daily life, we did some mixed methods work where we actually asked people about the routines that they, for which they developed to use cannabis for pain management, and it was just incredibly heterogeneous, excuse me. So something as simple as like using 2 drops of CBD oil twice a day for somebody who's, managing pain, versus, somebody who says that they medicate with 5 milligrams of a 2-to-1 CBD to THC gummy, then vaping with a 2-to-1 cartridge, then microdosing for 2.5 milligrams every 2 hours, et cetera, et cetera. Just people have really detailed and personalized routines that they match onto their own symptoms, which is just much, much different than what you typically see within the stringent design of a clinical trial, many of which it's, take this pill twice a day and see what happens. One other trend that I want to highlight, then going back to the beginning of the talk, is this substitution of cannabis for pain medications. So this was from that same cohort of 1,321 people with chronic pain. And we asked people, well, did you substitute cannabis for any other medications? And most of them did. About 80% said that they substituted cannabis for a wide variety of medications, most commonly opioids. And of those, almost 70% said that they totally stopped using opioids when they, as a result of using cannabis, mostly because of better symptom management and fewer negative side effects. And this trend largely held among many of the other medication classes, with most people who are doing this substitution saying that they're stopped or decreased, with a few saying that there is no change or it increased a little bit. And given that, this was with medical cannabis, I was interested to see if this held with CBD products that have, again, less than that 0.3% THC, and the same trend held. This paper is published in 2021 in the Journal of Pain, among a cohort of people with fibromyalgia. And of the 878 who are currently using CBD products, again, many said that they substituted these CBD products for opioids, benzodiazepines, gabapentinoids, and that the result was cessation of use or decreased use. And, just to also show you that this is not a finding that only I have put out there, this is just a sampling of the numerous papers that have been published from other places in the US, from Canada, and from Israel that have reported similar findings. So moving then on to, issues for properly uptaking and using cannabis in a medical context. So talking about some stigma and some barriers, which can stem from multiple sources. So because cannabis remains Schedule 1, their disclosure to a healthcare professional can result in a loss of status or respect because of the perception of being a drug user or pothead. Many people who are, in healthcare now, because of the Schedule 1 status and the associated propaganda with that, may not have learned anything about cannabis, so they might not be able to offer advice about how to properly use these. And in some extreme cases, this might mean that if anybody talks about cannabis in any context, that just results in pushing people into addiction services without actually trying to understand why they're using cannabis and if they might be finding benefit. So going along with that stigma, then, the barriers to this include legal issues. That Schedule 1 status is really the elephant in the room there that's causing a lot of issues, both for physicians who might not feel, or healthcare providers who might not feel comfortable talking about cannabis with their patients and giving advice on how to use a Schedule 1 substance. But then again, that lack of healthcare provider knowledge, cost being a big thing as well, because there's no insurance coverage for a Schedule 1 drug. And then lastly, especially in states that don't have the sort of infrastructure that we have in Michigan, knowing where and how to purchase these things in a safe way, especially given the contamination issues that I discussed earlier, can be a big issue. And so I've looked a little bit into what this communication breakdown and how these stigma and barriers might result in some communication breakdown. And so here's just a couple of examples there. Patients selecting cannabis products, only 2.6 doing so via consultation with a medical provider versus almost 55% via consultation with a bud tender who's a dispensary employee. These data came from that same cohort of 1,321 people that I mentioned earlier. And then on the CBD product side of things, most people select them through personal research or through advice from the employee at place of purchase, versus just about a sixth of them due to the endorsement of a medical professional. So this also extends into that substitution arena, which, is concerning because, it's one thing if somebody, say, substitutes cannabis for an NSAID, but if you're thinking about, for an antidepressant, for a disease-modifying anti-rheumatic drug, it's really important to consider how that change might affect somebody's healthcare. And in a paper published in the Journal of Cannabis Research with my colleagues, we actually asked people, how did you make the decision about substituting cannabis for different products and their different medication? And almost uniformly, that influence was largely driven by people's own experiences rather than the advice of a healthcare provider. So you can see, for example, for opioids, about 88% said that their own experience versus 28% for a healthcare provider. Lastly, in this section, I'll just talk briefly about medical provider knowledge. So we interviewed physicians at a large Midwestern institution and about their knowledge and attitudes towards medical cannabis, as well as assessing their knowledge based on some of the scientific literature. And we found that generally physicians lack confidence and comfort in their own knowledge to integrate cannabis into treatment regimens, with only 8% rating themselves as moderately through extremely knowledgeable about cannabis, while only 61% were not at all, or over 61% were not at all or slightly knowledgeable. And only 18% were somewhat or very comfortable incorporating cannabis into treatment regimens versus 64% being somewhat or very uncomfortable. and of that, battery of questions on the risk benefits and use of cannabinoids that we pulled from the scientific literature, only about 58% of those were accurately answered. So in summary then, we know that medical cannabis clinical trials for pain are limited, but people are using cannabis for pain regardless, and that use is growing. So in my mind, the practical thing to do here is to figure out how to work with people in a patient-centric way to effectively communicate and help them minimize harms, maximize benefits, and think of this and conceptualize it as a clinical opportunity that can help with shared decision-making to give people the care that they need. So things that I like to consider in this are developing a treatment plan with symptom tracking. So if somebody doesn't know how cannabis is affecting their pain, but they're using it, giving them a standard way to say, okay, well, how does it affect your pain? Let's look back at the past week when you've been using this pain diary and see how, when you use it, what sorts of change in your pain scores or anxiety or sleep issues that often go hand in hand with pain, how those things change. There's also lots of other sorts of practical tips here. So especially for people who are new to cannabis or trying out a different administration route, starting low and going slow is so incredibly important so that people don't, end up in that same camp of, eating an edible, waiting 30 minutes, eating more, waiting 30 minutes, eating more, and then getting so uncomfortable that they either need to go to a hospital or need other help to deal with the feelings that are arising. And so I think of this both in terms of the doses that people take. So, very low doses to start out if they've not used a route of administration or say THC before, but also then starting with CBD alone or a high CBD to low THC product so that, this is the harm reduction technique to start out with the lower risk thing first, and then adding in THC only if CBD is not helpful on its own. Considering different administration routes, like I talked about before. So if somebody is smoking, they might not know about tinctures or edibles or topicals, which could potentially both provide longer lasting symptom control, as well as avoiding that sort of quick spike of effect and then loss of effect that requires smoking lots of times a day. And then, of course, as I mentioned before, building partnerships with patients, which requires flexible mentality of just really trying to hold the space for them, allowing them to share their experiences, what was helpful, what was not, and then working from that space of shared knowledge and awareness. And then lastly, sharing useful legal information. So for example, there's a recent paper that was published in JAMA Psychiatry showing that legal CBD products that have less than 0.3% THC can still cause a positive drug test. This was a small study, only 14 people, but half of them did have positive drug tests after taking CBD products that were legal for a month, just because that small amount of THC perhaps can build up and cause that. And then just a note on THC, should people want to add this in states with no legal medical cannabis, it is still possible to obtain legal THC through FDA-approved Marinol or Dronabinol, which is a Schedule III drug, can be used off-label. But then in states like Michigan, we have medical cannabis licenses, we have adult use cannabis products, and people can pick and choose and use those products as they wish. And then lastly, just to add a couple thoughts from David Nutt, who's a very prominent pharmacologist and studies drugs in the UK. I really enjoyed this recent commentary that he wrote where he framed the use of cannabis in this way, is that every time a medicine is prescribed, an N=1 experiment is being conducted. And in some patients, that experiment works, and in others, it fails. And really, cannabis is no different. Anytime you give somebody a benzodiazepine or an NSAID or something like that, that might work for them. It might not. And in fact, we know with most pain medications that they only work on a subset of people. And in others, they either provide no effect or the negative effects outweigh the benefit. So going back to that point of having a flexible mentality, I think if we conceptualize cannabis in this way, it provides that support and holds the space that people who are, trialing these products need to really have the chance to give them a fair shot and then continue if they need and discontinue if it's not helpful. So with that, thank you so much for your kind attention, and I'd be delighted to take any questions.
So much for that fabulous presentation, Dr. Boehnke. So as Dr. Binky mentioned, this is the time for questions. So if you have any questions, please feel free to add them to the Q&A section or the chat. And we do have one question to start off with. It's from Betty. What would a reasonable starting dose be for a patient wanting to use CBD for osteoarthritis pain?
Yeah, so that's a great question. I think that, going back to that idea of start low, go slow, often, and there, are quite a few papers published at this point that are, what people have done is pulled together a panel of experts, asked them this very question, not necessarily for osteoarthritis pain, but just generally like what kind of CBD or THC dose should people start at? And generally the consensus that I've seen there is taking 5 to 10 milligrams 2 to 3 times a day of CBD, having this be a tincture or a capsule product. And then if that provides a benefit, great. If not, then increasing that dose every few days, maybe having a dose ceiling of maybe 50 to 100 milligrams before adding in some THC. But, again, going back to that symptom tracking and monitoring, making sure that people do a good job of, seeing if there is an actual effect there.
Question comes from Carolyn. Which agency is responsible for quality complaints, or who should patients report issues to?
Yeah, that's a great question. I think that so there's the Marijuana Regulatory Agency, which is part of the Licensing and Regulatory Affairs, I believe, because they oversee a lot of the licensing that occurs for medical cannabis products, that I believe they have a place to report quality complaints. I'm very curious to hear from my colleagues at the Washtenaw County Health Department if they have anything to add to that, just to make sure I'm not missing anything.
Yes. I think that's a really good point. And just I was also trying to monitor the questions too, so I missed part of your answer. But did you mention Lara? Yes,
Lara and MRA. Mm-hmm.
Exactly. Yep. And now actually it's the Cannabis Regulatory Agency is transitioned their name. Mm-hmm. Mm-hmm.
Awesome.
Great. Thank you. And I would just probably also say for the FDA approved products, right? Because there are a few of those like that you mentioned. Is that correct? I would say then you can also report the complaints to the FDA as well.
That's right. But for most like medical cannabis products, since those they don't go through any FDA. Yeah, you can't do anything with those with the FDA, unfortunately. But yep, absolutely. With like dronabinol or Epidiolex, if somebody's taking those, it can definitely make those things known to the drug manufacturer, to the FDA.
And we have another question, and this one is from Amy. And I apologize because I'm probably going to mispronounce some things. But can you briefly speak on the ideas behind Indica versus Sativa products and whether any studies have compared them?
Yeah, I love this question because this is something that really comes up both for patients and healthcare providers all the time. And so, there's some sense that Indica and Sativa provide different effects. So some people will say Sativas are more uplifting, energetic, energizing, while Indicas have more of like a couch lock, sedative feeling that is in some ways better for pain. The problem is scientifically, none of these things have really borne out in the assessment of the products available in medical cannabis dispensaries. And at this point, there's just so many different types of cannabis that if at one point there was a pure Indica or a pure Sativa, that's not necessarily true in the same way anymore. I think it is well known that different types of cannabis do have different effects, and a lot of that is affected both by the cannabinoids, which I touched on, but also there's many other compounds in the plant like terpenes responsible for taste and odor that do have interactive effects with cannabinoids as well as effects in and of themselves. So like lavender, for example, has lavender essential oil, the same terpenes of which can be found in cannabis, does have some anxiolytic properties. So I think there's now some more sophisticated big data approaches where people are trying to map those terpene profiles and sorts of terpene clusters with changes in symptoms or properties of cannabis, but that's at a pretty nascent phase at this point in time. So yeah, great question. Thank you.
And we have another one. I let my Michigan medical card expire and use recreational tinctures, THC and CBD for pain management. Is the quality the same for medical and recreational?
Great question. Yeah, so it's my sense that the testing requirements are largely the same for the medical and adult use products. I think the main difference is by not having a medical license, there's a couple things. One, there's a 10% excise tax on recreational products that you avoid if you have a medical cannabis product or license and buy those products. So depending on how much it costs to get that license renewed, both the doctor's visits and the fees to the state, it can potentially be a money saver to have that license. And then there are some products that are only available medically but are not available to recreational consumers, I believe. It's been a while since I've been in a dispensary, but when I went last, there was some difference there. So, but in terms of, to the best of my knowledge, the quality standards are the same and what is enforced.
Thank you. And just to add to that, I believe the medical cannabis actually does have to go through a little bit more rigorous testing as well. So I think that is part of it too, is just more testing for the medical. So theoretically, could catch more things.
Oh, that's good to know. I didn't know that.
Yeah, yeah. Great. Let's see. Well, please, if you have any other questions, please add them into either the Q&A or the chat, and we'll make sure to answer them. And as we wait for more questions to be entered, we have some of our own as well. And so the first one is, what steps can healthcare providers take to share information about medical cannabis and its effects on pain relief with their patients? And how can they work to reduce the stigma of cannabis amongst patients?
Yeah, great question. So, how to share the effects. I mean, I think this would be a great place to, have some sort of standard handouts or pamphlets or things like that. I've seen these developed both at like colleges and different healthcare practices of saying like, this is the standard dose of THC or CBD, and these are the different effect onsets of smoking and vaping versus edibles, and obviously done in a well communicated, not like hyper scientific way. You're not using a lot of jargon, I guess I should say. But I think that sort of baseline information would be really valuable to give to patients who are interested about this, as well as then, when somebody brings this up, especially in the pain context, doing a lot of listening. I feel like, going back to that point of stigma and how to overcome that, I think being a kind and gentle and thoughtful listener, and really trying to even offer like, hey, if cannabis is something that you're using or that you're interested in, I'm open to having a discussion. We don't have to have it. But if that's something that you've thought about, like, I just want you to know that is a safe place, that this is a safe place that we can have those discussions. And then if the person brings that up, really making sure that you follow through on your word of doing that. I do think it would also be helpful from a data collection, electronic medical records standpoint to have just a little bit more thoughtfulness in how medical cannabis use can be disclosed and reported on a standardized way. Because I believe at this point, a lot of the diagnostic codes and things for that relate more to cannabis abuse and addiction rather than medical cannabis use. And a lot of the, any of that extra information that would be answered gets, put in as more of a pretext note opposed to a standard situation. So I think that would be an institutional way to really start to acknowledge that this is something that people are doing, and to be more okay with that and show that support for patients who are doing this. Yeah, I think that's pretty much it that I could think of, at least at this time.
Thank you. Yes, and another great question. Thank you, Randy. Is the slideshow available to review or download? It will be. So everything, the recordings from all of our webinar series, as well as the slides, will be added to our website. And I will add that to our chat now. It is washtenaw.org/marijuana. And we also have materials that we've developed on our website as well that they're for anybody to use. So feel free to use that too, and stay tuned for when we add those items to the website, the recordings and the slides. Great. And another question that has come in from Amy: how might you talk with a patient about cannabis use utilizing a risk reduction model for opioid use?
Yep, this is another good question. This is also one of the things that I think some people find to be pretty controversial at this point in time, because at this point, to my knowledge, there's not really a best practices for opioid tapering at this point. So I think that if somebody is using cannabis, they're also using opioids, they're interested in reducing their use of opioids and, supplementing or substituting with cannabis. I think one of the really important things to do as a baseline assessment is to help understand, what symptoms, what things are they really managing with those opioids? Because for some people it is pain, for quite a few people it's mood issues, and then for a lot of people it's also sleep. So once there's an assessment of how that opioid use pattern is actually going, and you can get a sense of, okay, what times of day, what sorts of doses, and what symptoms are being managed, then thinking of how to map cannabis on top of that could be a thoughtful way to go. So for example, there have been a couple studies, typically in people who don't have pain, but they show some synergism between use of THC containing cannabis and opioids, such that the pain relief in, standard pain tests is the same with that smaller dose of both the THC and opioid together as the higher dose of opioid alone. So with that in mind, seeing if it's possible to, at that time that somebody's already taking an opioid, to maybe take a slightly smaller dose and have a very small dose of cannabis at that time, to see if that combined use could potentially provide the same sort of relief as that higher dose of opioid by itself. And this, theoretically could be with THC containing products. It could happen with CBD. That would, be really great, just given that lower risk profile. And if somebody's, say, using opioids for more of, a mood or anxiety issue, then that's a place that CBD could potentially fit in a more thoughtful way, just given that it has more of these anxiolytic properties. But again, a lot of really thoughtful conversations with the patient, lots of check-ins as they're starting to experiment and track what they're doing, I think would be really key here, because what we would want to avoid is somebody, making huge moves too quickly and then potentially having severe issues that result from that. So being incremental, being thoughtful, being slow and holding that space within that assessment model, I think would be a great way to proceed, especially if the patient brings it up and wants to figure out how to do that in a concerted and thoughtful way.
Great, thank you so much. We are nearing the end of our time today with Dr. Kevin Boehnke. If you do have another burning question, please feel free to add it. But until then, I just wanted to share some housekeeping items. In the chat, I'm adding a brief evaluation, a link to that, either a bit.ly link or the SurveyMonkey link that it takes you to. And so we would love for you to complete the survey if you are able, so please do so. And then another housekeeping item is that our Cannabis in Practice webinar series continues next week. And I'm adding the title of the next one into our chat too. And the next webinar is entitled Update on Medical Cannabis Use in Pregnancy. It's by Lara Borgelt, PharmD. And that's on Wednesday, August 10th at 12 p.m. Eastern Time. And the registration information is listed there as well. Right. So it looks like no other questions have come in, and I see that we are pretty much at time. So please join me in giving a huge thank you to Dr. Kevin Boehnke for sharing all of his time and his knowledge and his talents with us today. We so appreciate your presentation.
Thank you so much for having me. It's been a delight to be here with y'all.
Thank you so much. And we hope everyone has a fabulous rest of their day. Thank you.